Hello, my name is Sharon Van Baylor, and I will be doing my clinical case presentation on a patient by the initials KB. KB's chief complaint is, I just want to kill myself and I'm tired of living like this doing meth. Brief HPI. KB is a 41-year-old white male with reported history of bipolar, presenting from St. Francis Medical Center emergency department on PEC for suicidal ideations with intent to overdose on crystal meth. Patient has stated that he has been shooting up meth and experiencing hallucinations. He then began to experience suicidal thoughts and thoughts about shooting up the rest of his meth, but decided to throw it down the street drain. He states that he was in a trance-like state. He also says that he threw his drugs down the drain due to not wanting to live that way. KB is an average-sized middle-aged man with unkempt appearance. He is missing several teeth and unkempt oily hair. KB is alert and oriented to self, place, and situation. Patient displays rapid speech, impulsivity, anxiety, disorganized thoughts, difficulties with concentration, difficulties with maintaining eye contact, and a hard time answering questions. KB reports he experienced visual hallucinations while using methamphetamines, denies auditory hallucinations or delusions. KB has been using illicit drugs since the age of 14. He reported using marijuana, cocaine, crystal meth, and heroin. He also reports that he has had 2 overdoses, denies any history of alcohol abuse. He states that he has been admitted to rehab facilities 4 times, and he has been hospitalized for his psychotic issues, but cannot recall how many times he has been admitted. Patient states that he is his highest level of education is a GED, and that he is currently homeless and unemployed with no relationships with his family. Upon physical examination, vital signs, his temp is 98.3, blood pressure is 122/75, heart rate is 120, and oxygen saturation is 95, and respirations are 20. Patient denies any history of hearing or eyesight issues, no discharge, no slurred speech, no shortness of breath, wheezing, coughing, no chest pains, palpitations, hypertension, no black tarry stools, constipation, nausea, vomiting, denies any burning and urination or increased urinary frequency, and denies UTIs. Patient also states that he does not have a history of falls nor decrease of range of motion. Endocrine wise, patient does not have any thyroid issues or blood sugar issues, no issues with hematological aspect as far as blood clots or receiving blood transfusions. As far as KB's stressors, he has interpersonal stressor in regards to being homeless and unemployed and the use of substance abuse, according to Hamrick and Hansen. The patient has a long history of substance abuse, and this ongoing abuse is likely contributing to a significant current manic episode and mood disorder. The patient reports being homeless and unemployed, which are significant stressors that can exacerbate mental health issues and contribute to feelings of instability and hopelessness. These stressors penetrate the line of resistance. Intrapersonal stressors, that KB is experiencing is his bipolar disorder. The patient is diagnosed with bipolar with a current manic episode. Bipolar disorder is a chronic mental illness characterized by extreme mood swings, including periods of mania and depression. Current manic episodes likely add significant stress to the patient's life, impact his ability to function and maintain stability. This penetrates the normal lines of defense. Psychological stressors that KB is experiencing is rapid speech, impulsivity, disorganized thoughts. These symptoms are indicative of a manic episode associated with bipolar disorder. They contribute to the patient's overall distress and difficulty functioning in daily life. Difficulties with concentrating and maintaining eye contact. These symptoms further suggest that the cognitive impairment often seen during manic episodes is present, and this penetrates the patient's psychological defense. According to the DSM-5, KB's diagnosis is bipolar disorder, current episode manic without psychotic features, being that the crystal meth caused his hallucinations. He is also diagnosed with stimulant dependence with stimulant-induced mood disorder. As far as differential diagnosis, he has a differential diagnosis of anxiety disorder, attention deficit hyperactivity disorder, and borderline personality disorder. What differentiates KB's diagnosis with anxiety disorder is that even though anxiety disorder includes generalized anxiety, panic disorders, social anxiety disorders, and it may present such as restlessness and irritability and difficulty concentrating, which can overlap with symptoms of manic episodes. However, anxiety disorders do not typically involve the distinct periods of elevated mood characteristics of bipolar disorder. As far as ADD, it is characterized as an inattention, hyperactivity, and impulsivity. Some symptoms such as impulsivity and distractibility may resemble features of a manic episode. However, in ADHD, these symptoms are typically chronic and pervasive across various settings, whereas in bipolar disorder, they occur during discrete manic and hypomanic episodes. The third one is borderline personality disorder, which it also shares features with bipolar disorder, including mood instability, impulsivity, difficulty with interpersonal relationships. However, the borderline personality disorder mood swings are typically more rapid and reactive to interpersonal stressors, whereas bipolar disorder mood episodes occur independently of external triggers and are characterized by distinct changes in moods and energy levels. As far as his medical history, KB does not have any significant medical history outside of his psychological issues. He has been diagnosed with ADHD and bipolar. He has drug allergies of Geodon and Haldol. Current medications, he was not able to tell us what he was currently on. However, he was able to tell us that he has not been on his psych meds for 2 weeks, and he gave a list of medications that he has been on before but refuses to take. These medicines include Zyprexa, Triliptol, lithium, Risperdal, and Depakote. However, after talking to him further, he decided or was open to the thought of increasing the dose of Depakote. He was receptive to that. His labs, his CMP results, creatinine was 0.80, BUN was 13, sodium was 138, potassium is 3.8, liver enzymes, AST is 30, ALT is 25, his CBC, his white blood cell count is 11, red blood cell count is 4.4, 0, hemoglobin is 12.7, and hematocrit is 37.9. His urine drug screen was positive for amphetamines. In regards to the plan of care, primary would be assessment and diagnosis. Medication management is considered secondary. Psychotherapy is tertiary, with substance use treatment, lifestyle modifications, health habits, and social support. All of those are considered tertiary. As far as the role competencies that the NP will have to play in this role, collaboration, consultation, and expert coach and guidance, especially expert coaching guidance in regards to him following up and doing outpatient interventions and lifestyle modifications to aid in him staying on the right track with his plan of care. But assessment and diagnosis, thorough assessment by mental health professionals to differentiate symptoms of bipolar from those induced by stimulant use. Diagnostic evaluation to determine the severity and nature of both conditions. In regards to his medication management, he would need to be placed on a mood stabilizer. So we decided Depakote. He did say that he started off at 500 milligrams, and I believe we wanted to increase that to, I want to say the highest was 900. Also, integrating the psychotherapy with the cognitive behavioral therapy and dialectical behavior therapy are beneficial in addressing both bipolar and substance use issues. And he would need to be, apparently, upon discharge, he would have to be placed in another rehab facility. And from there, I mean, that is part of the collaboration and consultation. Usually when they discharge patients from an acute psychiatric hospital, they do IOP and also have recommendations of a psychiatrist that they can talk to. And I do believe that has covered my plan of care. We talked about mood stabilizers, yes, and withdrawal, detoxing, lifestyle modifications, him being able to identify his triggers. According to Atigun, he is going to need a support system, so group therapy is suggested, highly suggested. Participating in group support groups for individuals with bipolar and or substance use disorders can provide additional encouragement and coping strategies. As far as follow-up and regular monitoring, ongoing monitoring by mental health professionals to assess medications effectively, monitoring side effects and adjusting treatment will be needed. So regular follow-up appointments will track progress, address any new symptoms and concerns, and provide ongoing support for KB. Thank you.